So, good evening, everyone. So, I am myself, Dr. Poona Chandra. First of all, at the outset, I would like to thank Ilan Kumar sir and all the chairs in the KOS committee for giving us this opportunity. So, this session will be for 1.5 hours. That is from 6 p.m. to 7:30 p.m. So, Dr. Mahesh Kumar is the chairperson. For some technical reasons, he is not able to log in. He will be logging in soon. And Dr. Anupama Kiran Kumar will be moderating the session throughout. So let me introduce Dr. Anupama Kiran Kumar. She's a retinal surgeon at Narayan Nethralaya. She has completed her basic medical education from KS Hegde, Mangalore, followed by DNB at Narayan Nethralaya. And also she has done her super specialty fellowship in vitreoretinal surgery at Narayan Nethralaya. She has won many awards like Best PG Presentation at KOS, Best Paper UVA, and also our video was selected among the top podium presentations at AOS. So I think if I tell everything, I may run into the time. So over to you, Anupama ma'am, to run the show.
Thank you, Dr. Poona Chandra. My co-chair, the co-chair on this session is Dr. Poona Chandra, and as he's been so kind to introduce me so politely, I would also like to introduce him to people who have not known him, which is, I think, a handful maybe. Dr. Poona Chandra has been my colleague, and I'm very lucky to work with him. He's completed his post-graduation from AFMC and went on to do a fellowship in vitreoretinal surgery in Narayan Nethralaya. He also has the additional qualification of doing electrophysiology from Moorfields Hospital, London, and also has completed a preceptorship in age-related diseases from Safe Sight Institute in Sydney. He's won several awards and is an esteemed speaker in several conferences, and I think we are lucky to have him with us. Let's start with our first talk. Our first talk is by Dr. Karthik Medha. Yes. Just one moment. Dr. Karthik will be speaking to us about OCT interpretations for retinal disorders. Now, this entire session is targeted towards general ophthalmic practitioners, and we hope that you can pick up some practice pearls from all our esteemed faculty. Dr. Karthik is the director of Karthik Nethralaya. He did his DNB at the Arvind Eye Hospital and went on to do a fellowship in vitreoretinal surgery from Sankara Nethralaya, Chennai. Over to you, Dr. Karthik. Ashwin, could you please play his video?
Yeah, good evening, everyone. Today I'll be speaking on OCT interpretation in retinal disorders. Now, as we all know, OCT is a non-invasive diagnostic tool which has revolutionized the way we understand retinal pathology. So when we do an OCT scan, we can use the inbuilt various scan patterns that are available. Some of the commonest ones which are used are the line scan, the cross-line scans, the raster scans, and the radial scans. Apart from this, there are special scans which are available to screen the optic nerve head and the nerve fiber layer. Now, during the OCT scan, it is possible for us to alter the scan location manually to move the scan to the region of our interest. Now, the indications of OCT in ocular use are many, but with respect to the retinal or the vitreoretinal interactions, OCT is used to evaluate pathologies right from the vitreoretinal interface up to the choroid. So before we get into see how we can evaluate an OCT scan, it is important for us to understand what a normal line scan looks like. So this is the 10-layer histology of the retina that we are all aware of. Now, in the OCT scan, the retina is visible as alternating bands of bright and dark lines or dark bands which are visible. The usual thing from the vitreous surface is that the vitreous is equilucent, followed by the internal limiting membrane, which is hyperreflective. This is followed by the nerve fiber layers and the nuclear layers. Now, to remember the nerve fiber layers, the plexiform layers, both the inner and outer plexiform layers, are hyperreflective, in contrast to which the ganglion cell layers and the nuclear layers, the inner nuclear layer and the outer nuclear layer, are hyperreflective in appearance. There are further other layers which I will dwell upon during the course of my talk. Now, whenever we speak about OCT, we explain things in terms of reflectivity, like we explain in terms of fluorescence for a fluorescent angiography. So structures are either graded as hyperreflective or hyporeflective. On a grayscale, the hyperreflective are more towards the white and hyporeflective is towards the black. And in the pseudocolor scale, the hyporeflective is towards the black-blue region of the spectrum, and the hyperreflective is towards the red-white spectrum, and with in between green and yellow regions, yellow and orange regions. Now, shadowing is a terminology used when the laser light is not able to penetrate a particular ocular structure, leading to shadow behind that structure. are usually seen behind hemorrhages, pigmentations, etc. Posterior reflectivity is used when there is these kind of bright reverberation echoes, reverberation reflectivity patterns seen behind any structure, usually seen behind scarring in the retinal layers. Now again, these are the other normal and abnormal structures within the retina, classified as high, medium, and low reflectivity. Now, once we have understood what reflectivity is, how and what we look for next in the OCT scan. So it is nice to follow a particular pattern to read scans. So this would prevent from skipping out on things and skipping out things and coming to a conclusion on what the OCT is demonstrating. The next is to look for deviations from normalcy. So analyze the layers separately and look for scans taken at various regions and not just the fovea. Following which we can look at if there are any additional structures apart from the normal structures, like the presence of drusen, CNVM, hemorrhages, fluid accumulation, pigment deposits, etc. And after evaluating all these things, we can group all these signs to come to a conclusion on what the scan is depicting. Now, while we are evaluating in the OCT image, we can again follow a set pattern. First thing is to look at the scan quality. Second is to look at the overall scan profile, followed by the foveal profile. Next, to identify whether the scan is running through the fovea or parafoveal region, and then carry out a structured assessment. Now, when we say scan quality, this is depicted by the presence of two terminologies that is used. It's either signal strength indicator or the sound to noise signal to noise ratio. So a high signal strength indicator or a very high means a good high signal strength indicator means a good scan, and a high signal to noise ratio means a poor scan. So this can also be seen graphically on most of the OCT screens, where a good signal strength is depicted in the green zone, whereas a poor signal strength is depicted in the red zone. Now, when there is a media opacity obscuring a good scan, then it could be helpful to dilate the pupil to evaluate, and also it is sometimes possible to negotiate by the side of the opacity to capture a scan of the macula. Following which we can look at the scan profile. Usually the OCT scans have a mild concavity to them. Now this can get exaggerated when we are looking at very high myopic eyes because of the shape of the eyeball, or it can become highly convex when we are looking at pathologies like choroidal hemangiomas or dome-shaped maculopathies, where there is an inverse pattern of what we see in this scan. Following which we can go ahead with the foveal profile. Normally the OCT scan has a smooth bell curve to it. Now this can get flattened or inverted in conditions like an macular membrane, or in cases of macular edema or a vitreomacular traction. Similarly, the bell curve can become very deep in pathologies like foveal atrophy, or if there is a macular hole, etc. Following which, it is very important to identify whether the scan line is running through the fovea, because there can be a wrong diagnosis of macular edema looking at the scan pattern if it is not known whether the scan line is running through the fovea or the parafoveal regions. Now, the way to identify the fovea is to connect the nerve fiber layer to see if it forms a smooth line with the autoplexiform layer. So now this is usually retained pretty well in pathological conditions as well. Like when we see this scan of a patient with CNVM, this continuity is maintained. Similarly, in this scan, which has gross macular edema, the continuity is maintained, which means to say that all these three scans are running through the foveal region. Following this, it is we can move on to the structured assessment. The structured assessment can begin at the RP layer, which is the most easiest to identify because it is the brightest layer seen on the normal OCT scan. Following which we can examine the RPE, examine posterior to the RP, and come anterior to the RP, in which way we will avoid missing out on important clues. Now, the RPE as such is a bright line seen on the OCT scan. Now, pathologies within the RPE is explained through these terms, like in this scan where there has been a rip of the RPE post intravitreal injection, or in this scan where there is an absence in the RPE and only the Brooks membrane is seen, where there is an interruption, or in this scan where there is an actual elevation of the RPE with a hyporeflective space in below it, which means it is a serous PED. Apart from this, the other structures that are usually visible posterior to the RPE band is the Brooks membrane. Now, the Brooks membrane and the RPE form a single complex in a normal OCT scan, and the Brooks membrane becomes independently visible to us when the RPE gets separated from the Brooks membrane because of drusen or other structures. The RPE can get detached also because of the presence of fluid in cases of serious PEDs, or hemorrhage in cases of hemorrhagic PEDs seen in conditions like PCVs, etc. There can be fibrovascular tissue which can grow underneath the RPE, leading to a fibrovascular PAD. And patients sometimes can also develop subretinal fibrosis beneath the RPE bands, between the RPE. Now, the choroid imaging and understanding is increasing of late. Since the RPE is scatters and grossly attenuates the OCT light, it is difficult to capture the choroidal layer in a spectral domain OCT. However, in a swept source OCT, because of the longer wavelength of light that is used, the penetration is deeper and penetration is better. Now, to circumvent the problem with the spectral domain OCT, a mirror artifact is used to enhance the choroidal imaging. Companies have understood this and brought out the EDI software, which actually creates the mirror artifact and automatically reinverts the image for us to be able to evaluate the choroid better. Choroid can also be involved in pathologies, like in cases of CSR and IPCB, where the choroidal thickness may have got increased. In cases of myopia, the choroid is actually thin. In diabetic retinopathy, choroidal thickness is also considered as a biomarker. So a patient with thicker choroid has a better prognostic value compared to a patient with thinner choroid. Following this, we can come to look at structures which are immediately anterior to the RPE band. Here, there's a change in the terminology a couple of years ago, where they have renamed the layers that we were seeing earlier. So this hyperreflective layer is the external limiting membrane, following which is the myoid zone, which is hyperreflective. The myoid zone is basically the Golgi apparatus of the photoreceptor inner segments. This is followed by this hyperreflective line, which has very high prognostic value, which is the ellipsoid zone. Now, this layer is basically the mitochondrial layer of the photoreceptor inner segments. This is followed by again a relatively hyporeflective layer, which is the photoreceptor outer segments. Now, this is followed by the interdigitization zone, which is the RPE engulfing the photoreceptor outer segment processes. Now, below this is the RPE layer, which is basically the RPE and the Brooks membrane, which is represented together not separate. Now, these lines are very important because their integrity means better response to therapy, and they are again lost in many diseases like ERM, dry AMD, and diabetic macular edema, where they have a prognostic value. Following which they can move on to the inter-retinal structures. Now, retinal edema can appear as hyporeflective and can be either diffuse or cystoid. Hemorrhages, hard exudates, soft exudates appear at various layers of the retinal layer, and all of them, including pigment clumps and scar tissue, appear hyperreflective on the OCT scan. Retinal edema can be again hyporeflective, and it has been classically described to be the spongy, cystoid, sensorineural detachment, or a vitreomacular traction, which is a diagnosis of OCT. Now, cystoid spaces can occur in the retina, which is hyporeflective. They occur in all vascular pathologies, degenerations, or ocular inflammations. Now, in the retinal vascular pathologies, the cystoid spaces usually occur in front of the enlaced nerve fiber layer. They're most common in the outer plexiform layer, then appear in the outer nuclear layer, in the plexiform, and in the inner nuclear layer. Rarely, they happen to be seen in the ganglion cell layer or the nerve fiber layer. Now, in comparison to this, cysts that are seen in CME or post-cataract surgery most commonly occur in the inner plexiform layer of the retina. Now, cysts in PRVO are classically limited to only one half of the vertical line scan, owing to the vascular supply of the pattern of vascular supply of the retina. Now, slowly by time, these cysts can enlarge and coalesce. So, large cyst running the full thickness of the macula can mean chronicity and usually associated with poor prognosis. Now, leakage from juxtafoveal microorganisms can also cause CMA patterns. Now, following this, we can move into the preretinal zone and the vitreoretinal interface disorders. Now, the preretinal zone pathologies would include the ERM, vitreoretinal tractions or vitreomacular tractions. Syneresis can be picked up on the current generation OCT, which enhances the vitreous visualization. Fibrovascular proliferation, neovascularizations of the disc or elsewhere can be picked up on OCT scans. Now, the retina also has certain potential spaces. These are spaces usually which do not have any fluid accumulation, but they accumulate fluid in cases of pathologies like the sub-RP space, sub-neurosensory retinal space, which accumulates fluid in CSR and SNT, sensorineural detachment, submyoid space, which is a split beneath the external limiting membrane, which accumulates fluid in cases of inflammatory pathologies like VKH, sub-ILM space, where blood can accumulate in conditions like bulbar retinopathy, sub-hyaloid space, where again fluid can accumulate in the process of posterior vitreous detachment developing, or blood can develop in cases of subhyaloid fluids. Now, apart from using OCT as a diagnostic tool, OCT is also used as a prognostic tool, helping us to predict what would may be the outcome following initiation of therapy. There are a lot of biomarkers which have been identified for different conditions to help us prognosticate the treatment. So this is in brief as to how we can evaluate an OCT macular scan. Thank you very much for the opportunity.
Thank you, Dr. Karthik, for that wonderfully comprehensive presentation. Would we take questions now, Dr. Poona Chandra, or shall we take it towards the end?
Yeah, I think the topics are different. I think we can take the questions now, 1 or 2 questions maybe.
Okay.
Yeah.
I'm not seeing any questions from the audience as yet, but I do have one specific question, specially targeted for general practitioners. Dr. Karthik, of late, we notice that a lot of people are doing premium IOLs, and OCT has become a standard practice pre-op. Do you agree with that?
Sorry, I think I missed on the question. The question was OCTs become a standard preoperatively?
Preoperatively in cataract. Would you agree with that? Do you think it's essential, or do you think that it could be skipped?
No, it depends. I mean, it depends on who is examining the retina as well. So if somebody who is not trained to examine the retina well, it is always safer to get an OCT. Pardon me?
We're talking about general practitioners. Do you think that we would miss something subtle, maybe, or do you think that just a good
Yes,
impression is more than enough?
correct. So if there is an option available to do an OCT scan, especially where the media is a little hazy and preventing us to do a good fundus examination with a 90D or a 78D by microscopy, it would be better to do an OCT scan to pick up on subtle lesions which could influence the eventual visual outcome. And it has become more of a practice even when we are counseling for premium IOLs to make sure that the retina is normal before we plan for premium IOLs, which would again influence the outcome.
Thank you, sir. Thank you so much. We'll address any additional questions as they come up. We can, I think, move on to our next presentation. Our next presenter is Dr. Poona Chandra. Dr. Poona Chandra has done extensive work in electrophysiology, and he'll be taking us through
Hope my slides are visible. Hello.
Yes, sir. Yes, sir. Yes, sir.
Okay, fine. Fine.
Sir, just a minute.
Yeah.
this very interesting topic of electrophysiology. You can go ahead.
Okay, fine. Thank you, Anupam ma'am, for a kind introduction. Okay, so I'll be talking on briefly on the electrophysiology, when and how, from the general ophthalmologist point of view. Okay, so we have different form of electrophysiological test, but basically I'll be talking mainly about the electroretinogram today. Okay, so in electroretinogram per se, there are different types, like there is a full-field ERG, pattern ERG, and also multifocal ERG. Let's try and understand as we go ahead. So basically, electroretinogram is nothing but it's the mass response of the retina to a luminance stimulus. Whenever you stimulate the retina with the light, there will be biochemical and ionic changes which happens in the photoreceptor and the RPE, which generates electric potential, which is recorded as electroretinogram. And there are different waveforms, just like we have PQRS and ECG, we have A wave, B wave, and oscillatory potentials in an ERG waveform. A wave is from photoreceptors, B wave is from bipolar, mainly from bipolar cells, with some contributions from Muller cells. And oscillatory potentials are seen as a deflection along the ascending limb of the B wave, which are produced from amacrine cells. So whenever we interpret an ERG, first thing we need to look at the implicit time, that is from the onset of stimulus to the peak or trough of a wave of interest, and also the amplitude. The amplitude is measured from trough of previous wave to the peak of wave of interest. For example, B wave amplitude is from trough of A wave to peak of B wave. So we need to look whether the implicit time is delayed or the amplitude is reduced. So there are different electrodes which are used to record a full field ERG. The one is placed on the cornea, which we call it as an active or a recording electrode. The other electrodes, 2 electrodes, are called reference electrode, which are placed near the lateral canthus, approximately at the level of retina. We call it as a reference electrode. And we place one ground or a neutral electrode just above the nasion. And to stimulate the retina, we use something called Gansfield Bowl. It is a standard bowl which comes with a various luminous intensity. The intensity of the luminance, which is measured in the candela per centimeter square, which can be varied depending on the photopic and the scotopic conditions. So when we do a full field ERG, usually we elicit two types of responses. One is dark adapted responses, which is recorded after 20 minutes of dark adaptation. The second one is the light adapted responses, that is recorded after 10 minutes of light adaptation. So let's try and look at how a normal ERG looks before going into the indications. So the normal ERG starts with the dark adapted responses, that is after 20 minutes of dark adaptation. The first response is the 0.01 ERG, which is the big positive deflection, followed by 30 and 30 hertz ERG. So not 30 hertz, 30 candela per centimeter square. So in the dark adapted 0.01 ERG, it represents purely a rod function. Once we increase the intensity of light, the A wave also starts appearing, which deepens as we increase the stimulus of intensity of the Gansfield light to the 30. So this will have contribution from both cones and rods. So oscillatory potentials are recorded again in the dark adapted state. So the light adapted responses, we have two responses. One is the single flash response, where after light adapting for 10 minutes, we stimulate the entire retina with single flash of light, and we get a waveform which represents predominantly cone activity. In the same light adapted state, if you stimulate the retina with a high frequency light of 30 hertz flicker, the rods literally can't respond at all at high frequency. It's such a high frequency of light. In this state, only it can give response only from the cones. So if you look at it in a dark adapted responses, we started with an isolated rod driven response, and we ended with an isolated cone driven response with a spectrum in between. So whenever we interpret an ERG, what we need to look into is whether the rod component is affected or the cone component is affected, or whether both are affected. So whatever I spoke, it was about the full field ERG, which was the response from the entire retina. So let's try and understand what exactly is a pattern ERG. As opposed to the full field ERG, which is a response to the luminance stimulus, the pattern ERG is a response to the contrast. We use a checkerboard to elicit the response, and there is no contribution from the peripheral retina. The response what we get is mainly from the posterior pole. So it has got two waves. So mainly first is the N95 35. We usually don't give much of importance to that. The most important waveforms for us in a pattern ERG is P50 and N95. The P50 measures the integrity of the macula. N95 measures the function of ganglion cells. So basically, it complements the VEP. For example, to distinguish between a pathology which is isolated to the macula or optic nerve, whether both are involved. For example, if we take a case of a advanced glaucomatous optic neuropathy, in which macula will be normal, we will have a normal P50 response, whereas N95 will be abnormal because ganglion cell will be dead. Okay, and this if you take an example of an advanced age-related macular degeneration, where macula per se is affected and P50 will also be affected, and obviously N95 will also get affected. So basically, it complements both VEP and ERG. So if, for example, if a full field ERG is normal, and if the pattern ERG is abnormal, so it indicates the disease is localized only to the macula, but entire retina is normal. Okay, if both are affected, means the disease is quite diffuse. So then comes the multifocal ERG. This is used even to detect the even a smallest foci of retinal dysfunction. So this is done using by stimulating the retina with either a 61 or 103 hexagonal elements with a central fixation point. At any point of time, only 50% of the elements are eliminated. So basically, whenever you eliminate these different points on the retina, we get a waveforms which corresponding to the each and every point on the macula, which we call it as multifocal ERG. So to summarize the different types of ERG, the full field ERG is the response from the entire retina. The pattern ERG is predominantly from the posterior pole. Multifocal ERG, we are checking each and every point on the macula. So these tests usually complement each other. So whenever we report an ERG, as I was telling, this is how an ERG report looks like. And just to make a mention, any ERG machine, it should have its own normative database. So that's what we have done at our institute. The whatever that is blue represents the normal value, The black represents the patient recording. So first, whenever you interpret an ERG, first we should look at whether the rod component is more affected or the cone component is more affected, or whether both are affected. And sometimes there could be electronegative waveforms in cases of inner retinal dysfunction. I'll explain with the case example. So this was a 10-year-old female who presented with blurred vision with a vision of 660 in both eyes. Macula had atrophic changes. She was born out of a consanguineous marriage. When you did an autofluorescence and an OCT, she had a classical picture of Stargardt's. When you did an ERG, just look at the dark adapted responses. The implicit time is delayed. Amplitude is also grossly reduced. And the same is been repeated in 30 and 30 candela per centimeter square ERG. And even the light adapted responses are also grossly delayed and also diminished. So basically this ERG is showing in this patient, both the cones and rod system, both are affected, indicating a cone rod dysfunction. So whenever you report an ERG, we use the term dysfunction, not the dystrophy. It could be because of anything. So why this classification important? Because in Stargardt's, ERG can be of 3 types. In type 1, there will be normal full field ERG, in which case the chances of progression is nil. If only cones are affected, there are 20% chance of progression. If both the cones and rods are affected, as in our case, there are 80% chance of progression. In a way, it also helps us to prognosticate the case. This patient had a ABCA4 mutation. The second case was a 24-year-old male who presented with blurred vision. In fact, he was referred to me as a case of malingering because his fundus appeared normal. So this was his OCT, which showed just the subfoveal cavitation, which looked like a photic retinopathy. But when he did an ERG, look at it. Just dark adapted responses are completely normal, whereas light adapted responses are unrecordable. So this is a case of achromatopsia. Why I'm calling this case as achromatopsia is, it is a form of cone dystrophy. Again, cone dystrophies can be early onset stationary and late onset progressive. So achromatopsia falls into early onset and a stationary disorder, which is a non-progressive disorder. So the second other case is a case of 27-year-old female who presented with history of night vision problem and a history suggestive of tunnel vision. Her central vision was quite okay. It was 6/9 and 6. She has had a classic picture of retinitis pigmentosa. So when we did an full, this is our OCT, which shows photoreceptor surviving only in the foveal region. If you look at the full field ERG, is unrecordable. Okay, but that is indicating severe both rod and cone system dysfunction. So in a typical case of RP, we need not do a full field ERG because the photoreceptors which are present in the foveal region are not enough to elicit the full field response. If at all, if you want to monitor the RP patient, you have to do multifocal or a pattern ERG. So this case again came for a routine checkup, had multiple fleck-like deposits, OCT was normal, no symptoms, ERG was also normal. So this is a case of benign fleck retina. One more case with a similar presentation, but this patient had a history of night vision problem. OCT was again normal, but if you look at the ERG, dark adapted responses are unrecordable, and there is an electronegative ERG. A wave is forming, but the B wave is not even reaching the baseline. So this is a case of fundus albipunctate. This is how ERG helps us to differentiate. So just a last case before I finish. This was a 54-year-old female who was a housewife, came for cataract surgery, and she was interested in multifocal IOL. And she had an history of taking hydroxychloroquine for 20 years for rheumatoid arthritis. OCT was absolutely normal. FAF had very subtle changes, but it was inconclusive. But you look at the multifocal ERG, there is a gross reduction in central responses. So she is definitely not a good candidate for multifocal ERG. So this is the specialty of ERG. It can pick up changes even though even before the structural changes ensure. Okay, I'll just skip the last case. So just to conclude, I would like to say electrophysiology is an important tool to diagnose in various diseases. It should always be followed by a clinical correlation, and additional genetic information, especially in cases of retinal dystrophy, adds to the strength. Thank you so much.
Thank you, Dr. Poona Chandra, for sharing a small slice of this extremely vast topic. I know it's taken a lot of effort to try and compress it into these 10 minutes. Would anyone else like to ask a question?
Yeah, I have a question for Dr. Poona Chandra. I'm Dr. Mahesh.
Yes, Dr. Mahesh.
Appreciate all the work that you do on macular dystrophies. Actually, most of the places like ours where we don't try to head ahead and go ahead and do anything much as a thing. Okay, so whenever the dystrophy comes, like we consider it to be as a dead end. So you go and do genetic analysis, right? So I would want to know, like, in whom do you feel that genetic analysis will make any sense, and how it will do? So that is, from whom do you advise genetic analysis, and how it will help further in their prognosis? Because that is what their question would be. The next one, like, what next after this?
Okay. To answer your question, to whom it makes sense to all the patients with retinal dystrophy. The reason being, so far we used to label retinal dystrophies as under a broad term like retinitis pigmentosa and Stargardt's. But recently, of late, we have learned that there are different gene mutation can cause the same phenotype. By doing a genetic testing, first we'll understand what is the gene causing this problem. For example, when you diagnose these problems, people will just go on Google. For example, if you type RP in Google, you will get 101 n number of information, which may not be relevant to them. But once we detect the genetic problem and if we give them, they themselves can keep a track of the research. For example, if they're for that particular gene mutation, in case if there are trials going on, so definitely they can expect something in the near future. So that is one thing. And the second scenario where it can help is the patients who are planning for a family. For example, someone is consanguineously married, even in some cases of non-consanguineous. So they know like they are affected. They want to know whether the progeny is affected, how it can be prevented. So this is the another scenario which we do genetic testing, ideally for all patients, as I said. But these scenarios, it becomes must. And the last question you were asking, how to do it. So before doing it, as you rightly mentioned, we need to counsel the patient because this is slightly a costlier test. They should not have an unusual expectation. We need to tell them what is the role of genetic testing. That's why in our institute, we do a counseling for 30 to 40 minutes before advising the test. And we collect the blood and we usually send it to a lab called MedGenome. So wherever you send the genetic, blood sample for genetic testing, make sure that that lab has a good retinal dystrophy panel. So not all lab, just because they do genetic analysis, doesn't mean that they'll pick up the mutation. So that, I hope I have answered your question.
Okay, thank you, Dr. Poona.
Yeah.
Thank you, Dr. Poona. Our next presenter is Dr. Aniket Shastri, and he'll be presenting about topography made easy. Now, hello, am I visible?
Yes, you're audible. You're audible.
Yes. Okay. Yeah. So, Dr. Aniket will be presenting about topography made easy, and this will be especially interesting since we have a whole bunch of posterior segment people over here. Dr. Aniket is a consultant in the Department of Cornea as well as Phaco and Refractive Surgery at MMGC Hubli, and he did his graduation from Bangalore Medical College and went on to do his post-graduation from Safdarjung Hospital in New Delhi. He is well trained in a whole plethora of corneal surgeries, including transplants like penetrating keratoplasty, lamellar keratoplasty. He's also had the experience of training and mentoring several students. So we look forward to this presentation, sir. Over to you, Dr. Aniket. Ashwin, can you please put up the sir's video?
Hello, everybody. My topic today is corneal topography. And as we all know, topography literally means study of land surfaces. What are the hills? What is the depth? What is the elevation? Similarly, when it comes to cornea, it literally means that we are mapping the various areas of the cornea. Its curvature, its elevation, what is the power, what is the thickness. And the devices to do this has been broadly divided into reflection-based devices, which are called as topographers, whereas the elevation-based devices, which we use now very frequently, are called as tomographers. Reflection-based devices are our traditional reflection-based devices. These are the topographers. We do use keratometers very frequently now for our IL calculation. And the elevation-based devices are actually the true topographers, as they give information about the posterior corneal surface as well. And based on the different principles, there are different devices. Opscan is based on slit scanning principle. Shine plug imaging is for pentacam. Similarly, Vscan is OCT based. Both the Galilei and the Sirius are a combination of Placido disc imaging and as well as shine plug imaging. Among these, the shine plug devices are the ones that are used the most and studied the most. And we need to know the concept of best fit sphere when we talk about elevation. Whenever we talk about any elevation differentiations on the earth, actually, we are comparing with sea level. There's no such natural reference surface when it comes to cornea. And so what happens is that we have to create an artificial one, and based on the mean central radii here, that of an examined surface, which is a corneal surface, the computer as such will build a reference body, and we'll be comparing with this reference body, and any point on the corneal surface above this reference body will become plus sign, any thing below that will become minus, and at the surface will become 0. And to help us out still, we have these colors where the plus is given a hot color, the minus is given a cool color, and 0 is given a neutral green color. If we apply the same thing to the cornea being prolate, actually the center goes above the reference sphere, and therefore you have this hot color. The mid periphery starts dipping, so it becomes minus, and thereby this is a cool blue color. When it comes to a astigmatic cornea, then the steeper axis dips below the reference body, and therefore it becomes a cooler color. Just like how the elevation has color coding, similarly the power maps and the Pachy maps also have color coding. So higher the corneal power and lower the thickness, it becomes red. So red is like dangerous signs. And these are some of the clinical applications that we use topography for, right from refractive surgery to ectatic disorders to phakic ring segments, toric IOL plannings. So when it comes to interpretation, we have the 4 maps which are always presented to us. We have the power map or the curvature map. We have the anterior and the posterior elevation maps. So we have the pachymetry map that gives us about the thickness. And we have some quantitative data that gives so many numbers. And this is how a pentacam display appears. This is how an Vscan is there with a quad map with quantitative data. And this is a series which has got its 4 maps along with the data. So basically there will be 4 maps along with whatever quantitative data, quite similar between all these maps, all these devices. Whenever the quantitative data comes, the data comes from the corneal front surface, the corneal back surface, the pachymetric data, and some additional data given to us. Need not be scared with so many numbers, only few are very important to us. And when we come here to the corneal front and back data, it is the quality of the scan is important. We need to know that most of the cornea is covered. So an OK is good. The Q value here is basically the asphericity of the normal anterior corneal surface, which ranges from -1 to 0. So if it goes below -1, it becomes hyperprolate or probably in keratoconus. If it nears 0 and goes into positive, it's post-myopic refractive surgery. K1, K2 is similar to what we get on our keratometers, the SIMK, what it's called as. And these are used to plan LASIK surgeries. And the astigmatism here, which is shown, should match the subjective refraction which we do in our clinics. Coming to the pachymetric data, the thinnest pachy at the thinnest location is important. It should be more than 470 microns. Otherwise, it's a red flag sign. And also, we need to know where is this thinnest location, and this it should not be more than 1 millimeters in your y-axis. That it should not be deviated more than 1 mm below along the y-axis. Another important point is the Kmax. This is very important data here. It should be less than 47.2 to be a relatively normal cornea. And this is important. The anterior chamber depth, the internal anterior chamber depth from the endothelium is more important in planning our phakic IOLs. And when it comes to display maps, all the 4 maps have to be studied for the shape of the maps and also some couple of quantitative data. The power map is the axial curvature map of the anterior corneal surface, and depending on the K values, if you see there is a shape that is being formed. So there are different shapes or patterns that is formed. You have the symmetrical shapes. Some shapes are asymmetrical, some shapes are skewing where the axis of one is not in line with the axis of the other. And there are some typical patterns there. So this is what a normal shape appears like. This is with the rule astigmatism, against the rule astigmatism, and oblique astigmatism. When it comes to dangerous patterns, this is what it is. This is superior steepening. This is asymmetric with superior steepening. inferior steepening and asymmetric with inferior steepening. These all point towards dangerous corneal surfaces. And this is what I talked about skewing. The two axes are not in line with each other. If this axis increases by more than 20/21, it is a dangerous sign. And these are the different patterns. You have the butterfly, you have the crab claw, you have the vertical D, and irregular pattern in advanced keratoconus and pellucid marginal degenerations. One thing to note is at a 4 millimeter zone, these 2 points above and below this center exactly, the value here should not, the difference should be less than 1.5 diopters. We know the concept of best fit sphere. One thing to know is that in the elevation map, emetrope usually will have a central island, and hourglass pattern is usually seen in astigmatic people, and it should be symmetrical and regular. Any abnormalities like skewing or tongue-shaped invasion into this hourglass pattern, skewing of the hourglass pattern irregular is abnormality. And we need to look at the values within this center 4 mm, which is important. Outside is always high, central 4 mm. On the anterior elevation map should be less than 12 microns, and the readings on the posterior should be less than 17 microns. Anything more is risk. Pachymetry maps, it should be concentric, if you see from the center to the outside, and it should be symmetrical. And things to look at, we already know, seeing the thinnest location and position has already been discussed. This is what I was talking about. It becomes asymmetrical, where there's a deviation in the x-axis here, and there's a deviation in the y-axis here of the thinnest location. This is our pellucid marginal degeneration, or a keratoglobus looks like. And nowadays, one thing that has been added to the pentacam display is your Berlin-Ambrosio ectosia display. And on your left-hand side are the elevation data, and on your right-hand side is your pachymetric data. And here there is a concept of enhanced best fit sphere. Typically, not much problem in a normal eye, but in keratoconus or an ectatic part, this ectatic part of the cornea is also used in calculation of the best fit sphere. So thereby, what happens is this best fit sphere becomes more steep, and this exact ectasia part is how much of the ectasia is not known. So what they thought was, let's take out the central 4 mm. We'll not use this for calculation. Only the mid periphery is used. Thereby, we'll have a flatter best fit sphere, and this is now enhanced. So in a normal eye, there's not much difference. If you see here between the best fit sphere and the new reference sphere, whereas in keratoconus or early keratoconus or suspect cases, this thing is enhanced. So on the first row is best fit sphere, the second row is our enhanced best fit sphere, and third is a difference between these two. There are color codes, so anything that is red is dangerous. It's quite an idiot proof, so everybody can make out. On the left-hand side, this is a normal cornea. On the right-hand side, this is an ectatic cornea. There's something called as a corneal thickness spatial profile and percentage thickness increase. Cornea is thinnest in the center and gradually keeps on increasing. So this is how it is displayed on a graph here, and the red line is the patient's line, and it should lie between these two standard deviations or the dotted lines. Until 6 millimeters, it should follow the same pattern, be parallel. In keratoconus, what happens is either before the 6 mm mark, it tries to deviate, it's not parallel, it leaves early, or it changes the shape. So that's what it gives information regarding borderline cases. And these are what I just discussed now. These are the values that's been summarized here regarding the suspicious signs on topography. So hopefully this is not the expression when we have a topography on our hands next time. I want to thank COSCON for the opportunity. Thank you so much.
So,
Thank you, Dr. Aniket. We'd like to take some questions now.
Aniket, this excellent presentation. Me being a retina surgeon, I was also able to understand some of it now. I mean, I remember reading this during my PG days, all this topography. So I have a question for you. Like, as we were discussing in the OCT, the question what we asked to Karthik. So do you think what's the role of this topography in a cataract surgery, as a routine cataract surgery? So when do you think, and I mean, one should think of getting a topo prior to a cataract surgery? Is it a must situation? Because like of late, most of this, even the OCT machines, like they're coming with this combination: A-scan, topography, OCT, and color fundus photo, something like that. So what's your opinion?
See, even we have an OCT machine at our center, and we don't do topography machine at our center, and we don't do topo for all our cataract tests. Okay. One thing which I see is most of our patients do have an auto K and an auto ref that comes to us.
Okay.
And when I advise a cataract surgery, I'll get an IOL master as well. Now, if there is any kind of discrepancy, probably in the axis or in the degree of in the power, probably, then I would probably have to think of doing a topography. Topography gives us many informations, especially if we are planning premium IOLs. I always do topography of all my cases in premium IOLs, all my multifocals, high-end torics. Okay. For multifocals, I want to rule out any kind of ocular surface irregularities, any kind of anterior segment, anterior Bowman's membrane dystrophies, any kind of irregularities. Because there, most of the time, if you see, I have this where ocular surface, there have been astigmatism when I was planning a multifocal. Should I put a multifocal? Should I put a toric multifocal? On slit lamp examination, clinical examination, not much, but on the ocular surface, it does. Sometimes what you have missed probably on a slit lamp in your busy schedule can be picked up by topo. Then what happens is you can correct the ocular surface, and over a period of 1 month, 2 months, then what happens is your toric becomes clear. And posterior corneal astigmatism is something that is important when you're planning a toric IOL. Probably that is when I do a topography as well, because it's against the rule astigmatism, and that does contribute. For example, it ranges somewhere in the range of 0.25 to 0.75. But what if it is 0.75 against the rule astigmatism, and your anterior segment, anterior corneal curvature astigmatism shows only around 0.75, and you think, okay, not a big deal, 0.75, 0.5, I will not treat. But it is 0.75 plus 0.75 of the posterior corneal astigmatism. And probably these are the cases I would recommend if there is a discrepancy between your IOL master reading and your keratometric readings. If there is a discrepancy between the astigmatism on the IOL master, the auto ref, or whatever the patient is using, probably the glasses you will come to know. And in cases of premium IOLs, I think they do deserve at least one topography prior to when they get such high-end intraocular lenses. Anything else to add? I think anyone else can add.
Thank you. I think you briefly, that was quite crisp, and I will try to answer and as concisely as possible.
Yeah.
Any other questions? Otherwise, over to Dr. Anupama.
Thank you, Dr. Aniket. I actually have one other question. How frequently do we repeat our topographies for our keratoconus patients? How frequently would you advise it? Are there any guidelines for this?
You want to advise? No specific guidelines, ma'am. I don't. What usually I do is two things. One is there is a clear-cut case of keratoconus. Young patient, I have done a C3R. I do my first baseline topography after 3 months. Then I repeat the next 2 topographies at 6 months, and then at every year. This is in a patient who already is a keratoconus. In a suspect case, I do it first three topographies every 3 months. In case of a young patient, probably if I feel that he may progress, something like that. In case of individuals who come to me after 25, 30, who have borderline topos or have a keratoconus, but they have an excellent vision and they've been diagnosed as keratoconus somewhere and they're scared as to what is supposed to do. And those people, usually my first 2 topos are 6 months and then every year till the age of 40.
All right. Thank you so much, sir. Thank you very much. Let's move on to our next speaker. Our next speaker is Dr. Mahesh Kumar. Dr. Mahesh Kumar is consultant vitreoretina surgeon at Netradhama. He did his undergraduation at the Government Medical College in Mysore and went on to do his master's from the RP Center in New Delhi. Dr. Mahesh is also chairing our session, and today he'll be speaking to us about fundus fluorescent angiography, one of the most basic retinal investigations and probably the hardest to interpret under certain circumstances. So over to you, Dr. Mahesh. Ashwin, could you put up Dr. Mahesh's presentation, please?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
What we'll do is, ma'am, I think we can go to Dr. Dhanraj's presentation. Maybe we can come back to him. We'll speak to him.
Okay, we'll go to the next presenter. I think that would be my presentation only.
Yeah.
So we can go ahead with that. Dr. Mahesh will join us sooner. Ashwin, could you shift to my presentation, please? The Vscan presentation. So today I'll be dealing with Vscan for everyday practice. And due to the constraint of time, I'll be specifically talking about the intraocular Vscans. Please play. Vscan for everyday practice. I'll be starting with the basic examination techniques and then discussing a few Vscan examinations of intraocular structures. As we all know, Vscan is an invaluable adjunct to clinical examination for various ocular as well as orbital diseases. With a proper understanding of the indications as well as a proper examination technique, one can gather a wealth of information from this simple tool. Let's start with the physics and the instrumentation. Ultrasound is basically a high-frequency acoustic wave using frequencies outside the normal hearing range. The probe consists of a quartz or a ceramic crystal that vibrates when a voltage is applied to it, generating a sound wave of constant frequency and amplitude. This is known as a piezoelectric effect. Ophthalmic ultrasounds use something called a pulse ecosystem, wherein the probe produces a sound wave that then passes through the ocular structures, creating echoes, and there is a small pause at which time the receiver receives these echoes and then processes it into a display unit, either as a linear display or as a dot display. Ophthalmic ultrasound uses short wavelengths because it has a shorter penetration but good resolution, and this works well for the eye because the eye is a relatively small structure. The probe generates frequencies around 20 megahertz. The A scan basically is an amplitude scan, which means that the resultant echoes are displayed as vertical waves from the baseline, and the amplitude of the wave is corresponding to the intensity of the echo. The B scan is a brightness scan, which means that the intensity of the echoes are displayed as multitude of dots, the brightness of which depends on the intensity of the echo. For a good examination, we now use an overlay of an A scan over the B scan image for a better interpretation. Gain is basically a relative unit of ultrasound intensity. It is expressed in decibels, and the gain can be adjusted to change the sensitivity of the display. It does not in no way alter the sound waves produced, but at higher gain, so we display weaker signals and decrease the resolution of an image. At lower gains, it removes the weaker signals but shows better resolution. We usually start at a lower gain and then move up or down as required. Coming to the indications of Vscan, in opaque media, it is used to visualize the posterior segment, such as in corneal opacification, in hyphemas, in cataracts, as well as vitreous hemorrhages and inflammation. In clear media scenarios, it could be used to examine ocular tumors, for topography, in retinal detachments, to check for after movements as well as PVD status to plan surgery, in cases of optic nerve abnormalities, such as pseudopapilledema, as well as in disc edema for the diagnosis as well as follow-up also. In cases of intraocular foreign bodies and in traumas, it is invaluable, and also to study extraocular muscles as well as the orbit. For a proper Vscan examination, we first need to understand the probe as well as the probe positioning. The Vscan probe has a piezoelectric crystal, and it also has a marker as shown in the image here. The relative placement of the marker with the relative position of the eye helps us understand which area of the eye we are imaging and how to interpret the resultant image as well. There are three cardinal positions for the Vscan: the axial scan, the transverse scan, and the longitudinal scan. In the axial scan, the probe is placed perpendicular to the cornea. It demonstrates the lesions in relation to the lens as well as the optic nerve. There are two types of axial scan, the superior as well as the nasal. So the vertical axial as well as the horizontal axial. In the vertical axial scan, the superior retina is shown superior to in the superior part of the image and the inferior retina in the inferior part of the image. The nasal, when the pointer is pointing nasally, the superior part of the image shows the nasal retina and the inferior part of the image shows the temporal retina or the macula. This is especially important to image the macula when you're planning some kind of an optical procedure to prognosticate the patient. The most commonly used examination technique is the transverse scan. Here the probe is placed always parallel to the limbus. The patient is asked to look towards the area of interest, and the probe is placed parallel to the opposite limbus. The pointer either marks point superiorly or nasally, depending on the position, as shown in the image. A sweep is done from the limbus to the fornix, pivoting the probe according to the contour of the eye. So the images are formed from the posterior pole right up to the periphery. The transfer scan basically gives us the lateral extent of a lesion and covers about 6 clock hours. The third probe position is the longitudinal scan. The longitudinal scan basically is a radial imaging of the retina. It represents the radial extent of a lesion and demonstrates only 1 clock hour per echogram, radially from the posterior pole to the equator or ora. It usually acts as an adjuvant to the transfer scan examination and is especially important in cases of intraocular tumors as well as in retinal tears. It always gives us the anterior-posterior extent of the lesion. Now, to be sure that you're doing a good Vscan examination, you need to specifically follow one single pattern every time you make an examination, which means that every time you do an examination, you follow specific steps and repeat them every time you do it for a different patient. I usually follow the pattern where I do my axial scans first, followed by a transfer scan, and then eventually a longitudinal scan. And I do it in the same fashion every single time, so I'm sure that I've examined every single part of the eye and have not missed anything. To obtain a high quality image, we need to place the lesion at the center of the scanning beam. The beam is perpendicular to the interface of the area of interest, and the lowest possible decibel gain, consistent with the maintenance of adequate intensity, should be used to optimize the resolution of the image. To get a complete information from your Vscan imaging, you need to do a topographic examination, a kinetic evaluation, as well as a quantitative assessment. The topographic assessment gives us the shape, border, location, as well as the extension of the lesion. The kinetic assessment helps us understand the movements as well as the after movements. And the quantitative assessment assesses reflectivity, attenuation, and structure of the abnormality. And having an A scan to correlate is always more helpful in this particular scenario. Coming to some common case examples. This, as you can see, is a normal B scan. It's an axial scan because we see the lens at the anterior part and the optic nerve head centered posteriorly. Here we can see a low to moderate intensity membrane echo, which seems quite irregular but has great after movements, and this is suggestive of a posterior vitreous detachment. Here we see a number of low to moderate intensity dot echoes in the vitreous cavity and also an irregular moderate intensity membrane echo with excellent after movements. This suggests a PVD with a vitreous hemorrhage. This of course needs to be correlated clinically to rule out other causes as well. In this particular video, we can again see an irregular low to moderate intensity membrane echo. In this case, it is attaching to the disc. And posterior to this membrane echo, we can see multiple dot echoes suggestive of debris. So this most likely would be a posterior vitreous detachment with a subhyaloid hemorrhage. In this case, we see a multiple moderate to high intensity dot echoes that persist even on decreasing the gain. They also do not have any aftershadowing, and there is an optically clear zone between the retina and these vitreous debris, which is classical of asteroid hyalosis. This is a case of endophthalmitis. Notice the multiple membrane as well as dot echoes of low to moderate intensity. You can also see the good after movements of the vitreous structures. When assessing a case of endophthalmitis, we also need to look at the thickness of the retinal coats, the choroidal, the ocular coats, and also check for intraocular foreign bodies in cases of trauma. Endophthalmitis could also be associated with retinal detachments as well as choroidal detachments. Here we see a dropped nucleus in the vitreous cavity with aftershadowing. This is an intraocular foreign body. As you can see, it is a high intensity echo in the vitreous cavity with a 100% spike and a significant aftershadowing. Here the vitreous cavity shows a moderate to high intensity uniform membrane echo attaching at the disc, suggestive of a retinal detachment. Note the after movements, which tend to be quite poor. Anterior to these membrane echoes, you can also see an irregular membrane echo of lower intensity and better after movements, suggestive of a posterior vitreous detachment as well. This particular configuration appears to be that of a regmatogenous retinal detachment. This is also a video for retinal detachment, but in this case, note that the after movements are much less than the previous case. Also, there seems to be a plateau-like orientation of this membrane, suggestive of a tractional retinal detachment. This particular Vscan shows an intraocular mass. The notable feature in this mass is the presence of intralesional high-intensity echoes with an aftershadowing, suggestive of calcification. An intraocular mass with a calcification would most likely be retinoblastoma. This particular image shows an intraocular cyst-like lesion with a high-intensity lesion inside the cyst, most likely cysticercus lesion with a scolex. You can also see membrane echoes showing a retinal detachment. These uniform, thick, high-intensity membrane echoes in a dome-shaped configuration are pathognomonic of choroidal detachment. This particular case appears to be a serous choroidal detachment. Here we see an intraocular mass lesion. The intraocular mass has a cholested-like appearance with an excavation of the choroid. The notable feature in this particular lesion is the presence of the internal silent zone. As you can see on the A-scan, there is an anterior 100% spike, there is a posterior 100% spike with a central optically clear zone, and that is suggestive of a choroidal melanoma. This is a choroidal osteoma. Note the high reflective lesion in the choroid with significant acoustic shadowing. Both these lesions are choroidal excavations. The notable feature here is the rounded edge of one of the excavations and the sharp edge of the other. The round-edged excavation most likely is a staphyloma. And if you see a staphyloma in one of the cataract patients, be sure to counsel for amblyopia because such patients may have been high myopes and could end up having amblyopic eyes. The sharp-edged choroidal excavation is a coloboma, and if you see this in the macula, again it implies a poor visual prognosis. This is the Vscan examination of the optic nerve head. The notable feature here is the presence of the fluid crescent. Normally, we would measure the optic nerve head and the fluid crescent, and in a case of disc edema, and then follow it over a period of time to see the disappearance of the fluid crescent and the reduction in the size of the optic nerve head, suggesting a good response to treatment. This is also an imaging of the optic nerve head. Here particularly notice the high reflective echo on the surface of the optic nerve head, suggestive of an optic nerve head drusen. This is the commonest cause of pseudopapilledema. This is also the Vscan imaging of the optic nerve head. Note the significant excavation suggestive of a total cup. Again, very important in prognosticating mature cataract cases. That's all we seem to have time for today. The most important thing to keep in mind is that correlation with clinical findings is essential to make a diagnosis. No investigation modality can stand alone. I hope this particular presentation has helped you all, and I would like to thank viewers for the opportunity. Thank you.
Okay. Thank you, Anupama. That was an excellent and a concise presentation. Okay, I just have one question. Again, to help and guide general ophthalmologists who are attending. So, in case if you have an retinal detachment in a mature cataract, so would you give any? Would you like to advise any tips on differentiating between it being an exudative and a tractional one?
So the most important thing to keep in mind, Dr. Poona, is when you're looking at a retinal detachment, you need to see the configuration of the retinal detachment. So like I had demonstrated, the regmatogenous retinal detachments have a typical V configuration. You also see associated PVDs. The tractional retinal detachments on the other, and also in regmatogenous retinal detachments, you have to see the posterior extent of the retinal detachment? Is it a closed funnel? Is it an open funnel? That helps us prognosticate. In cases of exudative retinal detachments, on the other hand, you look at positional shifting of the fluid. So your configuration changes with the position of the patient changing. So you have the patient in a supine position, and then you have the patient sitting up, and you can see the shifting fluid. The other, and a tractional retinal detachment, like I demonstrated in my video, has a very plateau-like appearance, and it's extremely taut. So this is how you would be able to differentiate the various types of retinal detachments. And of course, we will also be correlating clinically and looking at the other eye as well to make a more concise and comprehensive diagnosis.
Thank you. Basically, as you rightly mentioned at the end of presentation, we need to put everything together. No investigation should be taken in isolation. Okay, ma'am, over to you. I think Dr. Mahesh is ready. I think Ashwin, you need to go to the display Mahesh's presentation.
Yes, Ashwin will display the presentation, Dr. Mahesh, and you can ask him to change the slides as required. Or would you like to present?
No. I think it's their audio is there. He needs to go to the slideshow and select play from the beginning button.
All right.
Yeah.
Ashwin, did you get that?
Yeah, Ashwin, just share Dr. Mahesh's slide.
Okay, ma'am.
Yeah, go to the slideshow from the beginning.
Hi everyone. I'm Dr. Mahesh Kumar.
Is my screen shared right now?
At Netradama Super Specialty Eye Hospital. At the outset, I would like to thank Karnataka Ophthalmic Society for providing me this opportunity. I'll be talking about fundus fluorescent angiography. It's an arduous task to complete this within 10 minutes time, but I will try my best. The basic principle of fundus fluorescent angiography is it's a diagnostic technique that allows the sequential visualization of the blood flow simultaneously to the retinal, choroidal, and iris tissue as the fluorescent dye is injected into the bloodstream via the vein in the arm. The FA is based basically on the principle of fluorescence. The fluorescence is the luminescence which is maintained only by the continuous excitation. The emission stops at once the excitation stops. The sodium fluoride is a hydrocarbon that absorbs light energy between a blue range and fluoresces at a green or yellow range. What's basically happening over here is when the white light is passed through, there's an excitation filter, which is a blue barrier, which lets only the blue light to pass through the eye. And when the blue light reaches the retina where the fluorescence is passing through, the sodium fluoride gets excited and it lets the yellow light pass through, and there is a barrier filter which will let only the yellow light pass through, and which is captured by the charged coupled device. So basically, why is FFA done? It provides three main information: the flow characteristics in the blood vessels as the dye reaches and circulates through the retina and choroid. It records the fine details of the pigment epithelium and retinal circulation that may not otherwise be visible, and it gives a clear picture of the retinal vessels and assessment of their functional integrity. So basically, the dye of sodium fluorescent is an orange-red crystalline hydrocarbon. It has a molecular weight of about 376 kilodalton, and it's stable, highly water-soluble, and pharmacologically inert. Basically, 3 doses of sodium fluorescent are available: 10 ml of 5 fluorescent, 5 ml of 10% fluorescent, and 3 ml of 25% fluorescent. The most widely used, which we generally use, is around 5 ml of 10% solution. The side effects can range from as trivial as nausea and vomiting to something like orange discoloration of urine, vision tinged with yellow, staining of secretion, urticaria, fainting, and even the higher disorders like myocardial infarction and cardiac arrest has been noted. For the purpose of interpreting fundus fluorescent angiography, the eye can be considered to have 2 strict compartments. The retinal compartment, where the normal retinal blood vessels are impermeable to the fluorescent leakage, and there's a choroidal compartment where intravascular and extravascular spaces are in free communication due to the permeable capillaries. So you can see mainly over here, retinal capillaries doesn't let any dye to pass through out anywhere, and choroidal capillaries has got free areas to pass through where fluorescent can leak out. So the normal angiogram is divided into different phases. The first phase is the choroidal phase, where the fluorescent dye is only in the large choroidal blood vessels and few choroidal capillaries. The fluorescence at this particular stage is very minimal. Next comes the arterial phase, where the fluorescent dye is in the more and also within the retinal artery. There is increase in the fluorescence at this. Then comes the early venous phase, where the fluorescent dye is also in the tributaries of the central retinal vein. And the late venous phase, where fluorescent dye is noted in the entire choriocapillaries, retinal arteries, and veins. Whenever we read an FA, we should always cultivate the habit of reading the fluorescent angiography through all the phases, starting from the choroidal phase, arterial phase, early and late venous phase, and the late phase. So this is how a choroidal fluorescent angiography looks like. This is the early phase where the choroidal flush is there, and this is followed by arterial phase, followed by early venous phase, where you can see the walls of the veins getting hyperfluorescence, and then into the late venous phase, where entire vasculature can be clinically attributed, and the late phase. We have to always read through from this particular stage to the end, because only finding one particular stage can give us an erroneous reading. So that we now understood how the normal fluorescent angiogram looks like, we should look into the abdominal angiogram. Basically, it is divided into hyperfluorescent and hypofluorescence. Hyperfluorescence again is divided into leaking, pooling, staining, and a window defect. And hypofluorescence is basically two types, which is block fluorescence and vascular filling defects. Now we will try and learn about each type of hyperfluorescence. The first primarily hyperfluorescence is leakage. In this particular type of hyperfluorescence, there is a frank increase of dye from the early to late stage, which increases in both size and intensity. It is seen in particular conditions like neovascularization elsewhere, neovascularization of the disc, CNVM, cystoid macular edema, central serous retinopathy, and retinal vascular. This is how it generally looks like. In the early stage, you can start seeing the hyperfluorescence appearing at the areas of neovascularization elsewhere, which starts increasing in intensity as well as size as the fluorescent angiography passes through. Well, generally at the late phase, you can see a clear-cut hyperfluorescence happening at that stage. The similar condition we note in neovascularization of the disc. It's in the early venous phase, you will start noticing the leakage happening, which increases in intensity as well as size. Even central serous retinopathy is in a similar scenario. The hyperfluorescence starts happening at around late venous phase, and it starts increasing in intensity and size as we go through the fluorescent angiography. Macular edema ensues the similar fate. It starts around late venous phase and starts increase in intensity and size, and we get a beautiful flower petal pattern at the late stages of fluorescence. Now coming to the pooling. Pooling is a type of hyperfluorescence where there is an increase in intensity of the dye, but the size remained constant. One of the classic example of this is a pigment epithelial detachment. We'll see how that did. The early phase, you not notice anything. At around the late venous phase, you start noticing the hyperfluorescence appearing in. It increase in its intensity, but as you can see that the size remains the same. Of hyperfluorescence that is minimal in the early and the mid phase. It almost appears as a hyperfluorescence because it looks like a block fluorescence, but which becomes marked in the late phases and is likely to be due to staining. The classical example is scarring, where you can early stage you can see that it's a kind of a block fluorescence where the scarring tends to block the fluorescence happening from underneath, and it starts gradually getting hyperfluorescence as it starts gathering more of staining. Coming to the transmitted fluorescence or window defect, it's a mottled hyperfluorescence that appears at a very early stage, at around the choroidal phase only, and at the regions where RP atrophy is noted, and it is most likely due to window defect, and the intensity and the size tends to remain the same as we progress through the stages of the fundus fluorescent angiography. Geographical atrophy is the classical example for transmitted hyperfluorescence. You can see the hyperfluorescence starting very early stage of the choroidal fluorescence, and the intensity tends to increase a bit, but the size tends to remain the same. We can easily confirm with the optical coherence tomography at the same stage. Now coming to the set of hypofluorescence. It's a block fluorescence which appears as a dark lesion that remains constant throughout all phases, and it is indicated by the black fluorescence. A classical example of this is preretinal hemorrhage. We can see the block fluorescence, which is hypo, which remains stable almost through the entire course of the fluorescent angiography, and it is mainly due to the blockade of all the activity which is happening behind the bleed, which is covering everything. Subretinal hemorrhage is a similar example. You can see the hypofluorescence at the early stage and remains. The vascular filling defect is a hypofluorescence that is most prominent in the arteriovenous phase of the angiogram, and which is associated with the non-filling of the dye due to the functional or anatomical closure of the retinal vessels, and it is indicative of the capillary. As you can see the hypofluorescent spots appearing at the arteriovenous phase, and the hypofluorescence remain constant, and it looks like a jigsaw puzzle. There are a few limitations of fundus fluorescent angiography. The major one being it does not permit the study of choroidal vasculature, and the risk of severe adverse reaction is in the small group of patients. Inability to obtain an angiogram in patients with very high hemoglobin concentration or excessive serum proteins. The only absolute contraindication for fluorescent angiography is the past history of allergy to compounds containing iodine and past history of severe adverse effect following ingestion of fluorescent. The history of asthma, hay fever, cardiac failure, and hepatic failure are few of the contraindications. Thank you.
Thank you, Dr. Mahesh. Would anyone like to pose any questions? All right, just in the interest of discussion for our audience, would you like to highlight the role of FFA in NPDR, Dr. Mahesh? Would there be any role?
NPDR, like whenever it depends upon when the patient arrives. There are certain set of patients who we see clinically might be NPDR, but who haven't visited you for a very long time. Like maybe you will clinically you'll find it as NPDR, but still having a go in such a patients, you might able to find more of a lot of bigger CNP areas, if not the neovascularization. So yeah, it might be helpful in such a scenario, but I would generally not try and do much of a FFA in such a patients who we know for sure that it is very beginning of mild NPDR to moderate NPDR. But yeah, those who have not visited you for a very long duration, but clinically appearing as mild to moderate NPDR, but you might go and pick up some bigger PSCNP areas, and in a way sometimes a small NVs here and there, which can help you further ahead and help you treat with lasers.
Thank you, Dr. Mahesh. Also, when would you advise an FFA in cases of vein occlusions? At what stage?
When it comes to early stages, yeah, definitely not. Okay, I would do it only when I expect CNP areas or the frank NV which is already present, which will help me delineate the laser area for sectoral lasers. Otherwise, initial phases, I will generally, it won't give much of information, so I would tend to refrain.
Thank you, Dr. Mahesh. I also find FFA is useful in NPDRs where I'm looking at the fovea, especially to see the architecture around the fovea. So that's one of the reasons Yes, and in case of my vein occlusion, sometimes when I have non-responding patients to anti-VEGFs, I find having extensive CNP areas tends to lean towards non-response to the anti-VEGF. So that's one other indication that I do look at it as well.
Okay.
Thank you so much. Can we move on? Shall we move on to our next presentation now? Our next presentation is by Dr. Dhanraj Rao. I have Dr. Dhanraj. He'll be talking to us about the UVM, and he'll be teaching us some tips and tricks. Dr. Dhanraj did his undergraduate from KMC Manipal and went on to do his PG from Government Medical College in Mysore and his fellowship from LBPI. And I've been very lucky to have studied under him as well, and he's a wonderful teacher. So over to you, Dr. Dhanraj. Ashwin, could you play Sir's presentation, please?
Hello, everyone. At the outset, I would like to thank the organizers of COSCON 2021 for giving me this opportunity to talk a few words about UVM. UVM allows for real-time visualization of living tissues with near microscopic resolution over a limited range. It utilizes frequencies between 35 to 50 megahertz, providing a resolution between 50 to 70 microns. Main advantages of UBM are that one is the ability to visualize the structures behind the iris, and also it's valuable information that we can get in many cases of secondary angle. These are some of the conditions where UBM could be of use. The machine has a probe or a transducer which directs and also receives ultrasound signals from the tissue, and which is carried over to the device here, and the ultrasound signals are then converted to real-time images which are displayed on the screen like this. As I was saying, the main utility of UBM in glaucoma is the visualization of the structures behind the iris, as in this case of iris Bombay. Here you can see that the iris is attached to the lens here. There is convex bowing of the iris. The angle is completely closed. This is the ciliary process, the zonules, and this is the lens. It is a collection of fluid behind the iris which pushes it forward and causes angle closure. This is another case of trauma with the pupil block. You can see the two poles of the lens. This pole is quite close to the ciliary body, whereas this one is much away from it. This is because the zonules here are broken, so thus allowing the vitreous to push the lens and the iris forward, causing angle closure. In primary angle closure glaucoma, the main mechanisms of angle closure are relative pupil block and plateau iris syndrome. So plateau iris syndrome is a diagnosis which is made after performing the laser iridotomy, where there is residual angle closure. So when we get patients with residual angle closure, we would like to know the reason for that. And plateau iris is the most common mechanism. Here, the central anterior chamber depth is deep. The profile of the iris is flat. There is anterior angulation of the iris towards its root. The ciliary process is located anteriorly, and the space between the iris and the ciliary process is totally obliterated. So this anterior location of the ciliary body prevents the peripheral iris from falling back, thus causing progressive angle closure. There's another patient, a young patient, came with a history of sudden onset of blurred vision, pain, redness. He gave a history of taking some tablet for migraine. So when we did the UBM, the angle was closed. There was collection of fluid in the supraciliary space, and there was anterior rotation of the ciliary body. This is another section of the same patient where we can see the cornea, the iris, the ciliary process, and the fluid all in the same section. This is another case of drug-induced angle closure. UBM plays a very important role in diagnosing malignant glaucoma. So this patient had undergone cataract surgery many years ago, and he presented to us with sudden onset of pain, redness, and blurred vision. There was axial shallowing. The IOL has moved forward. There is bowing of the iris here. When we look at the ciliary process, the ciliary body, it is rotated anteriorly, which is very characteristic of malignant glaucoma. Whereas here you can see a case of pseudophakic pupil block where the ciliary body itself is normal. So there is bowing of the iris here causing angle closure. Here just performing a peripheral iridotomy will relieve the angle and will open the angle. The post-trauma, here you can see that the ciliary body is completely detached from the scleral spur. So you can see a continuation of the anterior chamber into the supraciliary space. So diagnosis of cyclodialysis cleft can be difficult sometimes because the anterior chamber is shallow in these patients and also there is hypotony. So performing gonioscopy and detecting is sometimes difficult. There's another patient with cyclodialysis cleft. You can see the cleft here, and this is following treatment, following cryotherapy, the cleft has healed. Another case of trauma with angle recession. Here you can see the split between the longitudinal and the circular fibers of ciliary body. Pseudoplateau iris. This is because of the presence of multiple iris and ciliary body cysts, which will give an appearance of plateau iris. Usually, this finding is incidental. When we do UBM for some other reason, we just detect it. Or when we want to look for plateau iris, incidentally we detect the ciliary body cysts. It's called pseudoplateau iris because it gives an appearance of plateau iris. This is just for academic interest. This pigmentary glaucoma. Here you can see the concavity of the iris rubbing against the lens and releasing pigments, causing pigmentary glaucoma. Microspirophakia is easily diagnosed clinically. There is shallow anterior chamber, there is lens which is spherical, lenticular myopia, but if you want to document it, when you do UBM, it will reveal the spherical nature of the lens and also the small diameter and long zonules, which are characteristic of microspirophakia. The limitations of UBM are that, of course, it is a contact procedure and it causes a lot of discomfort to the patient. And performing UBM in the immediate post-op period or in suspected case of open lobe injuries can be a little tricky sometimes. In patients who have narrow interpalpebral fissure, it may become difficult for us to place the silicone cups on the eye. Children may not cooperate for the procedure and you may have to take them up for examination under anesthesia. And position of the probe is no longer a limitation. Nowadays, we have probes where you can fit in cups and you can keep the probe in any position you like. Of course, the time taken for performing UBM is more. It is operator dependent. That means the person who performs the UBM should know what he's supposed to look for, and also he should have sufficient knowledge of the pathology and also the location of the pathology. To conclude, high frequency, high resolution UBM enhances our understanding of anterior pathology and can be invaluable in many clinical situations, providing the kind of information that cannot be obtained by any other method, thus guiding management decisions. Thank you for your patient listening.
Thank you, Dr. Dhanraj. I think we've just made it on time in our session. Would anyone like to ask any questions? All right, so I think we are pressed for time now, sir. I would like to conclude this session by thanking the organizers for this opportunity, and thank you to the chairperson, Dr. Mahesh Kumar, Dr. Karthik, Dr. Dhanraj, Dr. Poona Chandra, and Dr. Aniket for making this session a success. I hope it's benefited some of the general practitioners. And we'd close for now. Thank you very much, everybody. Are there any other questions or anybody would like to add anything? In that case, let's conclude. Thank you, everybody. Good night.